Few topics in sexual health carry as much emotional charge as penis size. It shows up in private worries, locker room myths, online marketing, pornography, comedy, and quiet moments of self-doubt. Many men absorb the message early that bigger must mean better, better for pleasure, better for masculinity, better for confidence, better for being desired. By the time they reach adulthood, that belief may feel so established that it hardly seems worth questioning. Yet, when people finally hear the medical reality, many are startled. The gap between what society suggests and what anatomy research and real sexual experience actually show is remarkably wide. In practice, concern about size is often less about measurements and more about meaning. A man may not be thinking only about length or girth. He may be thinking about whether he is enough, whether a partner will compare him to someone else, whether he matches what he has seen on screen, or whether his body will be judged before he is even known as a person. Those fears can be powerful, particularly because they attach themselves to a part of the body that is intimate, visible in certain sexual contexts, and culturally loaded with symbolism. That is why reassurance alone is sometimes not enough. Telling someone not to worry does not always undo years of messaging that linked body parts to worth. What the evidence shows, however, is both simpler and more reassuring than popular culture would have people believe. Average erect penis size is usually smaller than many people assume. Human perception is not especially accurate in this area. Slightly above average sizes are often mentally exaggerated, and people routinely guess measurements incorrectly. Add to that the distortions created by pornography, camera angles, selective casting, and endless online comparison, and it becomes easy to see why so many men believe they are below average when they are not. In medicine, this mismatch comes up constantly. Someone may arrive convinced that their body is unusually small, while objective measurements place them squarely within the normal range. Another detail many people do not realize is that penile size is not a fixed, perfectly stable number in daily life. Bodies change from moment to moment. Blood flow, room temperature, stress, hydration, arousal, medication, circulation, and hormone fluctuations can all influence how the penis looks and feels at any given time. Even the difference between a relaxed state and a highly aroused state can be dramatic. This does not mean measurements are meaningless in a research setting, but it does mean the body is far more dynamic than most people think. Someone may decide they know exactly what their body is based on one moment of observation, when in reality physiology is always moving. For many couples, though, the more important issue is not measurement but function. How does this body feel in a sexual relationship? Is intimacy pleasurable? Is there arousal, communication, connection, and comfort? Those questions matter much more to sexual satisfaction than cultural scripts tend to acknowledge. The vaginal canal is elastic and responsive. Many of the most sensitive areas involved in pleasure are not necessarily deep inside the body. For a large number of people, factors such as arousal, trust, pace, lubrication, clitoral stimulation, emotional safety, and attentiveness matter far more than whether a penis is slightly longer or thicker. This does not mean size never matters to anyone in any context. Preferences do exist, but it does mean that the simplistic belief that bigger automatically equals better is not supported by the broader reality of sexual function. That distinction matters because insecurity can drive people toward decisions they do not fully understand. Cosmetic and sexual enhancement industries increasingly market procedures to people who feel vulnerable about their genitals. Men are told they can become more confident, more desirable, more impressive, or more sexually successful if they increase penile girth or length. Women are told parallel stories about breasts, labia tightness, youthfulness, and visual ideals that often have little to do with comfort or health. The marketing language is polished, but the emotional lever is old: create insecurity, then sell relief. This is where the conversation becomes more complicated. On one hand, people have the right to make choices about their own bodies. If an informed adult understands the risks and benefits of a cosmetic procedure and decides it is right for them, that autonomy deserves respect. On the other hand, bodily autonomy does not remove the need for careful medical judgment, ethical standards, and honest counseling. A person can be free to choose and still deserve protection from misleading information, poor technique, or professionals working beyond their expertise. That tension is especially important in procedures involving the genitals. These are not casual body areas. They involve intricate blood supply, nerve pathways, erectile tissue, skin properties, sexual function, and high emotional stakes. If an enhancement is going to be performed, the practitioner must understand not only injection technique, but also the full anatomy and the complications that can arise if something goes wrong. From a medical perspective, That is why so many specialists argue that procedures involving the penis should be handled by physicians with deep experience in penile anatomy and reconstructive consequences, not by anyone who merely happens to use fillers elsewhere in the body. A similar problem exists in female sexual medicine. Many women are marketed expensive genital treatments for symptoms that may have more straightforward explanations and cheaper, evidence-based solutions. A woman struggling with pain, dryness, low desire, or menopausal changes may be sold a high-cost procedure when what she actually needs is hormone support, pelvic floor therapy, lubrication, relationship counseling, or education about how normal anatomy changes over time. The issue is not only the procedure itself. It is whether the person offering it truly understands the problem they are claiming to treat. This matters because intimate body concerns can make people unusually persuasive targets. If someone is ashamed, frightened, or preoccupied with a part of their body, they may be especially vulnerable to dramatic promises. They may not ask the same skeptical questions they would ask before buying something less personal. They may assume that if a treatment is being offered in a professional setting, it must be well studied and appropriate. But not every marketed intervention is supported by strong evidence, and not every clinician advertising expertise actually has comprehensive sexual medicine training. There is another emotional layer here that deserves attention: body dysmorphia and persistent genital-focused anxiety. Some people think about their penis size, labia, vulva, or other body parts occasionally and move on. Others think about it constantly. They avoid intimacy, compare themselves obsessively, feel distressed in dating situations, or interpret unrelated setbacks through the lens of their perceived bodily flaw. When concern becomes that consuming, it may no longer be just a cosmetic preference. It may reflect a deeper psychological struggle that deserves compassionate treatment therapy, especially when it addresses body image, anxiety, and sexual self-worth can be profoundly helpful. Seeking that help does not mean the concern is imaginary. It means the suffering is real enough to deserve full care. The same pressure-filled thinking appears in other parts of sexual culture as well. People begin to treat sexual experiences like performances to be graded. Squirting becomes a status symbol instead of simply one possible response among many. Orgasm becomes a pass-fail endpoint rather than part of a much larger landscape of pleasure. Someone may begin to believe that a partner must climax in a certain visible way, or that sex only counts if it follows a narrow script. But real intimacy is far more varied than that. Some people squirt and enjoy it. Some squirt and dislike it. Some never do and have deeply satisfying sex. Some orgasms are intense and unmistakable. Others are quieter, more diffuse, or less visible from the outside. None of this makes one body better than another. That is why sexual health education has to begin with a broader question than what is ideal. It has to ask what is normal, healthy, pleasurable, and true for real human bodies. Once people understand that diversity is the rule rather than the exception, many of these anxieties begin to loosen. Bodies vary, responses vary, preferences vary. The goal is not to conform to a manufactured image, but to understand one's own body honestly and care for it well. From that foundation, more nuanced questions about enhancement, confidence, pleasure, and sexual skill can be approached thoughtfully rather than fearfully. Once the emotional weight around penis size, genital appearance, and sexual performance is brought into the open, the next step is to sort through what is medically true, what is culturally exaggerated, and what is simply misunderstood. This matters because many people make decisions about their bodies based less on anatomy and evidence than on social pressure, embarrassment, and misinformation. When the topic is intimate, people are often willing to spend large amounts of money, tolerate significant risk, and believe claims they would question in any other area of medicine. In the case of penile enhancement, one of the most common current approaches involves injectable fillers, often hyaluronic acid-based products used to increase girth. From a purely technical standpoint, this is not an absurd idea. Hyaluronic acid has long been used elsewhere in medicine and aesthetics. It is familiar to many clinicians. It is dissolvable in some contexts, and it offers a non-surgical route for volume enhancement, so the existence of the technique itself is not the central problem. The real issue is who is offering it, how it is being taught, what evidence supports it, which patients are appropriate candidates, and whether anyone is being honest about limitations, complications, and long-term outcomes. That concern becomes even more important when a procedure gains popularity before broad medical standards have been established. In ideal medicine, a technique becomes widely discussed, studied, openly published, compared, refined, and taught in a transparent way. If outcomes vary, experts can review the data and improve the method. If complications occur, the field learns from them. But in many parts of the sexual wellness market, Techniques are sometimes promoted in a semi-proprietary way, almost as branded secrets rather than openly shared medical practices. That creates a dangerous gap between marketing and science if doctors do not fully know what others are doing, how they are doing it, and what outcomes they are seeing. It becomes difficult to judge whether a treatment is truly effective, reproducible, or safe. This lack of transparency affects patients directly. A man may hear that a certain injection works, but what does that really mean? Does it improve appearance in a flaccid state, an erect state, or both? For how long? How often are touch, sensation, symmetry, or function altered? What is the risk of lumps, migration, vascular compromise, dissatisfaction, or the need for reversal? If those answers are unclear, then informed consent becomes shaky. A person may be agreeing to a procedure without truly understanding what the likely experience will be months later. There is also a practical surgical principle that applies here. No one should perform a procedure if they are not equipped to manage the complications. Genital anatomy is not forgiving. The penis contains complex vascular channels, erectile tissue, skin planes, and delicate structures that do not behave exactly like the face or other cosmetic sites. A practitioner may be excellent with filler in one part of the body and still lack the depth of anatomical and reconstructive experience needed here. This is why many specialists argue that genital procedures belong primarily in the hands of urologists or others with substantial genital surgical expertise. Not because other doctors are inherently careless, but because anatomy matters, and when something goes wrong, knowledge of that anatomy becomes crucial. At the same time, it is worth acknowledging the ethical complexity. If patients are clearly seeking these procedures, and if trained urologists refuse to engage entirely, the demand does not disappear. It often shifts to less qualified settings. Then the same specialists who avoided the procedure end up managing the complications. That creates a difficult tension within medicine. Professionals may be skeptical of the trend, but if the trend is real and likely to persist, there is also an argument for bringing the work into better trained, more evidence-based hands rather than leaving it to whoever markets most aggressively. This is one reason why some physicians argue that enhancement procedures should not be taboo subjects within urology. They should be studied honestly, taught responsibly if appropriate, and discussed without ridicule. Still, not every concern about penis size should lead to a procedure. In many cases, the first and most important treatment is education. A man may believe his penis is too small because he has internalized visual standards that were never realistic in the first place. He may not know that most partners are not evaluating him the way he imagines. He may not understand how much of sexual satisfaction depends on arousal, communication, foreplay, and partner-specific technique rather than simple dimensions. He may not know that visual media are heavily distorted by selection bias, camera work, and performance expectations. Once people learn these things, the emotional urgency around changing the body sometimes softens significantly. That same pattern appears in female genital concerns. A woman may be distressed by the appearance of her labia without realizing that vulvas vary enormously in color, shape, asymmetry, and tissue prominence. Some people have fuller labia minora, some have less visible inner lips, some notice changes after childbirth, hormonal shifts, or menopause. Many never received any education at all about what normal diversity looks like. In that vacuum, edited images and beauty norms can take over. People begin to believe there is one ideal version of a body part that, in reality, comes in a wide range of healthy forms. Hormones add another layer that is often overlooked. After menopause, the labia minora and surrounding tissues may shrink or change because of declining estrogen levels. Vaginal and vulvar tissues can become thinner, drier, and more fragile. Yet at the same time, cultural imagery often presents a minimal labia aesthetic as youthful or desirable, which creates a strange and misleading message. Some of the features people are encouraged to surgically create can resemble the low hormone changes that later cause discomfort. This is where medical education becomes essential. A person deserves to know not just what something looks like, but what it does, how hormones influence it, and whether changing it will improve comfort or only alter appearance. Some patients do have legitimate physical reasons for genital procedures. Labial tissue can cause friction, discomfort with exercise, pain during intimacy, or functional interference with clothing and activity. Some men do pursue penile interventions after thoughtful counseling and remain satisfied with their decisions. The point is not that cosmetic procedures are always wrong. The point is that the motivation, anatomy, psychological context, and expertise of the treating clinician matter enormously. A similar need for nuance appears in conversations about squirting and orgasm. These topics are often framed in culture as if they are milestones or proof of sexual success. But physiology is more varied than that. Squirting is real, and for some women it is pleasurable or exciting. For others, it's messy, distracting, or emotionally uncomfortable. Fluid release during sexual stimulation may involve urine to varying degrees, which does not make it pathological or shameful, but it also does not make it mandatory. A woman who does not squirt is not sexually limited, and one who does is not automatically having better sex. Too often, a natural variation in response gets turned into a performance measure. The same is true for orgasm itself. There is a strong tendency to search for a single definitive way to recognize it, produce it, or classify it. But orgasm is a physiologic event with real muscular and neurologic features, and it also exists within a much broader, subjective experience of pleasure. Rhythmic pelvic floor contractions are part of the classic physical pattern, yet not every intensely pleasurable sexual experience fits neatly into a simple category. Some people feel powerful waves of pleasure without a clearly defined climax. Others have very obvious orgasms, and others have subtler ones. Hormones, medication, emotional state, body familiarity, and the amount of total body stimulation all influence the experience. One especially important myth to challenge is that orgasm is the only measure of whether sex was good. Many people, especially men who have been taught to equate success with climax, feel pressure to get their partner there every time. But this can create anxiety for everyone involved. For many women, the arousal state leading up to orgasm can be deeply pleasurable on its own, and a satisfying sexual experience does not always require a dramatic endpoint. That does not mean orgasm is unimportant. It means pleasure is broader than the finish line. When couples focus only on the result, they often miss the experience itself. Research increasingly supports the idea that orgasm intensity can depend on the amount and variety of nerve stimulation involved. The body is not a single button machine. Touch to the breast, buttocks, vulva, clitoris, vagina, skin, and other erogenous areas can all contribute to arousal pathways. This is one reason why whole body sexual engagement often feels more intense and satisfying than narrow, repetitive genital focus alone. Bodies respond to context, novelty, safety, and sensory richness. In practice, that means better sex often comes from broader attention and less rigid thinking, not from chasing a single outcome. When patients understand these nuances, something important happens. Shame loses some of its power. A man who thought his worth rested on size begins to see that pleasure and confidence are not measured in inches. A woman who worried her body did not look right learns that normal anatomy is far more diverse than she was ever told. A couple that felt pressure to perform according to a script begins to recognize that real sexuality is responsive, variable, and deeply individual. And once that shift occurs, decisions about enhancement, pleasure, and sexual well-being can be made from a more grounded place, less driven by panic, and more informed by truth. When conversations about sexual health move beyond myths and pressure, people often discover that the most meaningful improvements come not from dramatic interventions, but from understanding the fundamentals of how the body works. Once the noise of comparison and unrealistic expectations fades, attention can return to the factors that actually support satisfying intimacy, physical health, emotional safety, communication, and self-knowledge. These elements may sound simple, but they are powerful because they influence nearly every part of sexual function. Take erections, for example. Many men worry about erectile performance at some point in their lives. While medications such as sildenafil or tadalafil can be helpful and are widely used, the physiology behind erections is closely tied to overall cardiovascular health. An erection is essentially a vascular event. Blood must flow efficiently into the penile tissues and remain there long enough for firmness to occur. Anything that interferes with circulation, smoking, poorly controlled blood pressure, high cholesterol, diabetes, or lack of physical activity can affect this process. Because of this, the lifestyle habits that protect the heart often protect sexual function as well. Regular exercise improves circulation, strengthens blood vessels, and helps regulate hormones. Adequate sleep supports testosterone production and energy levels. Limiting alcohol intake prevents the temporary nerve and blood flow suppression that can weaken erections. Maintaining a healthy weight reduces inflammation and improves metabolic health. When people commit to these habits, they often notice changes beyond sexual performance, better mood, sharper thinking, improved stamina, and increased confidence in their bodies. Stress management is another surprisingly important piece of the puzzle. The same nervous system that supports arousal also responds strongly to anxiety. When someone feels pressure to perform or worried about disappointing a partner, the body may shift into a state of tension that interferes with erection and pleasure. Learning how to relax, whether through exercise, meditation, breathing techniques, or simply slowing down during intimacy can help restore balance between the mind and the body. In some cases, couples benefit from intentionally creating time for closeness that is not immediately focused on intercourse. This allows the nervous system to relax and reconnect with sensation rather than performance. An important concept that many people overlook is that sexual experiences do not have to follow a single rigid script. Cultural messages often suggest that sex requires a fully erect penis, vaginal penetration, and simultaneous orgasms to count as successful. In reality, human intimacy is far more flexible than that. Couples can share pleasure through touch, oral stimulation, manual stimulation, kissing, or simply exploring each other's bodies without rushing toward a specific outcome. When people free themselves from narrow definitions of sex, they often find that anxiety decreases and enjoyment increases. This broader view can also help couples navigate differences in sexual desire. It is very common for partners to have mismatched levels of interest at certain times in their relationship. One person may feel eager for intimacy while the other is tired, stressed, or simply not in the mood. Rather than treating this as a failure, some couples find it helpful to create intentional time for connection. Instead of planning only traditional date nights, they might set aside what could be called an intimacy evening, a period where they focus on closeness, affection, and attention to each other without demanding that intercourse must occur. Sometimes these moments naturally lead to sexual activity. Other times they remain a space for emotional connection. Either outcome can strengthen the relationship. Another area where education makes a meaningful difference is masturbation. Despite being one of the most common human behaviors, it is often surrounded by moral judgment or misunderstanding. Scientifically speaking, masturbation is a normal form of sexual expression. It allows individuals to learn how their bodies respond to stimulation, discover what types of touch feel pleasurable, and experience orgasm without relying on another person's availability. In fact, many clinicians view it as a healthy component of sexual self-knowledge.